Uh, Hello, everyone. Thank you very much for joining for today's session on medical architecture post-COVID, a new theory. Today's session is part of series of webinars being organized by Faculty of Architecture and Design, Manav Rachna University. Manav Rachna Educational Institutes are brainchild of Dr. O.P. Bhalla, a visible symbol of knowledge, experience, and excellence. Manav Rachna University provides high quality education in various fields like engineering, management, architecture, design, and arts. I am Professor Colonel Sanjay Gupta. I am Director of Faculty of Architecture and Design at Manav Rachna University. It is time to introduce the panelists. Sir, I'll request kindly raise your hand once I talk about you, sir. Firstly, I'll talk about eminent personality, Professor Dr. ANIL DEWAN. Dr. ANIL DEWAN is a senior professor, Department of Architecture at School of Planning and Architecture, New Delhi. He has been very active in the area of healthcare architecture and has been part of innumerable hospital design projects. He has taught not only architecture, not only in the architecture design studios, but also in the various hospital to the various hospital administrators like AIIMS, New Delhi. He has been part of many WHO, World Health Organization committees. He is a distinguished fellow of Institute of Hospital Engineering. He has recently conducted teachers training program in emerging areas in hospital planning, design, construction, and facilities management. Incidentally, I was also a student when I was doing course, online course through Swayam, which I discussed with him earlier. Next was architect Sanjay Surya. He is alumnus of School of Planning and Architecture, Delhi, with 20 years experience. He specializes in landscape architecture and is an educator. He is presently head of the department with Faculty of Architecture and Design at Manav Rachna University. Professor DINESH BHARDWAJ is also alumnus of SP Delhi. He has almost 40 years experience. He is a specialist in Vastu and hospital architecture. He is presently Professor Design Chair at Manav Rachna. Now, a little bit of housekeeping before we start the session. In case anybody has any doubt, just write it in the chat box. We'll try to answer the questions or queries during the session, or maybe at the end of the session, we'll have time for questions. Now, without wasting any further time, I'll turn it over to Professor Sanjay Surya, who's moderator of today's session. Over to Sanjay.
Good afternoon, everyone. On 17th November 2019, a COVID-19 case was first reported in Wuhan, Hubei, China. On March 11, 2020, the World Health Organization declared the outbreak a pandemic, as over 8.66 million cases have been confirmed in more than 130 countries and territories, and at least 460,000 people have died from the disease. Over the course of few days, the lives of millions of people have drastically changed. Public health responses around the world have included travel restrictions, curfew, event cancellation, school closures, as well as quarantines of all of Italy and Chinese province of Hubei. In the name of public security, state authorities have implemented screening methods at airports and train stations. And excessive coronavirus public monitoring, such as facial recognition technology that can detect elevated temperature in crowds or flag citizen not wearing a face mask, while app use the personal health data of citizens. In the meanwhile, millions of people are isolated inside a new type of bunker. In the Hubei province, a new 25,000 square meter hospital was constructed in only 10 days. Worldwide effect of pandemic also includes social and economic instability, xenophobia and racism, and voluntary prisons encouraged by staying at home movement. There is a strong connection between health and architecture. Since ancient times, healthcare has been associated with the construction and the use of specialized medical building and structure. Architecture helps share the quality of our environment, and contribute to health and well-being. Topics concerning wealth have been stimulating architectural innovation at different scales. Territorial and urban development projects as well as architecture and interior design. Health has often stimulated speculative design and experimental proposal within the architectural discipline, as many works of famous architects such as Alvar Aalto, Franco Albini, Ignazio Gardella, and the theories of Le Corbusier give attention to the psychological and physical well-being. When millions of people are isolated and working from home, what features should home have? When people can't travel, what is the role of the hotels? When crowds are not allowed at the public spaces, how cities and public spaces change? In terms of health centers and interior design, last but not the least, what are the hygienic architectural details of the pandemic reality? With this, I'll give you a short story about the history of pandemic, and we'll start with a small video.
We're not getting the audio.
एक मिनट सर.
As humans organize themselves into larger, more densely populated cities, the potential for infectious disease becomes ever more present. Massive urban areas are like a ticking time bomb for infection, with humans, animals, food, garbage, and sewage stacked tightly on top of each other. It sets the stage for the perfect breeding ground for disease. Our ancient ancestors lived in small, isolated tribes that had very little opportunity to spread germs beyond their community. But after the advent of agriculture, tribes abandoned their nomadic lifestyles and organized into stationary civilizations. Since the dawn of civilization, mankind has dealt with epidemics, plagues, and pandemics. For most of history, city life consisted of overcrowded, unsanitary conditions. Food would often be prepared next to open sewers, while rats, cockroaches, and rotting corpses polluted the drinking water. These early cities also featured humans and animals living in close proximity to one another, conditions that are strikingly similar to those in Wuhan, China, the source of the coronavirus outbreak. These tight living quarters gave rise to the spread of zoonotic diseases, which are contagions transferred from animals to humans, such as COVID-19. Zoonotic diseases have been around since the earliest cities, but they would not become pandemics because these cities were isolated from one another. Once civilizations expanded into vast trading empires, the possibility for widespread disease was unleashed. The first major pandemic was the plague of Justinian, which struck the Byzantine Empire in the year 541 AD. The bacterium responsible has been identified as Yersinia pestis, commonly known as bubonic plague, a pathogen carried by rats and transferred to humans through fleas. After the plague had run its course, 25 to 50 million people had died, which was about a quarter of the Earth's population then. The plague returned with a vengeance 800 years later as the most infamous pandemic in human history. In 1347, ships returned to the shores of Sicily filled with sailors stricken by a mysterious illness that formed dark swellings, or buboes, in the armpits and groin. This symptom led to the nickname Black Death. The Venetians banned sailors from entering their cities for 40 days. In Italy, this was called 40 giorni, which means 40 days, and explains where we get the word quarantine in English. While these quarantine efforts did help to deter the outbreak, in the end, the Black Death took up to 200 million lives across Eurasia. Europeans also had to endure many endemic diseases like measles, chickenpox, and especially smallpox, which killed millions over several centuries. Ironically, these endemics would pave the way for Europeans to colonize the Americas. Native Americans lacked any kind of immunity to these foreign pathogens, and once exposed, over 20 million or 90% of the pre-Columbian population would be wiped out. In the end, it would not be steel or guns that would conquer the New World, but infectious germs. And perhaps we are still feeling the after effect of the horrendous Spanish flu to this day. The most recent mass pandemic struck in 1918 and infected 500 million worldwide. Unlike most diseases, Spanish flu impacted young adults the hardest. Half of those that died were between the ages of 20 and 40, and 99% were under the age of 65. By the end of 1920, Spanish flu claimed the lives of 50 to 100 million. Since these dark ages, we have made great advancements in sanitation, plumbing, medicine, and personal hygiene. It is highly unlikely that COVID-19 will come anywhere close to Black Death or Spanish flu, but this does not mean it should be taken lightly. As a species, we must evolve, learn, and adapt if we want to survive. As humans
With this introduction, I would like to bring in our first panelist, Dr. Anil Dewan. Over to you, Dr. Anil Dewan, sir.
Thank you, Sanjay Surya sir. Thank you for calling me. Thank you, Colonel Saab. Thank you, BHARDWAJ ji. Actually, my senior, my mentor, and my guru, ANUJ SOOD, was to speak before me, but because of some technical issues, he's not been able to connect. So I would like to speak whatever he was to say also, so that we get a continuum and we follow the structure we had prepared for this webinar today. So SOOD sir was to speak on architecture and what architecture can do for health. Till all this time, medical architecture was a subject which people would say, what is your contribution? What has medical architecture to do with general architecture? If you do good architecture, you do good medical architecture also. But today, medical architecture is to teach city planners, regional planners, urban designers, building engineers, transport planners, and all building related professionals, IT people, how to do healthy environments. We have to have health for everybody. So I see ANUJ SOOD on my screen now. So maybe have SOOD sir first, and then I'll continue with my speech. Could we have him now? Sanjay sir, can you see him? Because I can see him here, and maybe we could have him.
I'm trying to add him, but he's not there with us. Sir, you continue with it.
Okay. I continue. So what I want to say is that in my school we have 12 departments. So we talk about transport planning first. Transport planners have to do last mile connectivity. They have to do mobility for all. So we have to have inclusive environments for everybody. And in the post-COVID new normal, we have to maintain social distancing and we have to take care of all the people. So we were shifting towards public transport and people sharing their modes and means of transport, but now people are preferring their own personal means of transport. We are going into non-motorized transports, we are going into cycling, we are going into e-rickshaws, we are going into electric mobility. So in transportation sectors, there's a lot which is changing. In the housing sector, we are getting into cities without slums, human settlements that are away from each other, like we saw in the film here. So we have to do a lot for housing. In housing, we have to ensure that we are able to isolate people at home. We are able to provide quarantine facilities for people. We are able to treat people at home. So home care, hospital into your home, is the new theory for hospital planning, not only in India, but all over the world. In India, because we are a low income, low resource economy, it is very important for us to take care of our sick people at home. And it is here that the technology of artificial intelligence, big data, about apps which are in our smartphones, and how we can use television, telephones, smartphones, and internet connectivity to reach to the people who are not reachable. So now we are going to have satellites in the air which will provide internet connectivity to very remote houses. So houses and housing would have very good home care. So we're talking about chemotherapy at home, we're talking about intensive care units at home, we're talking about remote monitoring, we're talking about telemedicine, how we can take care of people's, lots of people's at home. So then we come to work environments, workspaces, and we're going to show you a film on that. In the film, we're talking about a 6 feet office and how do we maintain a 6 feet distance between people so that they can go back to the new normal and we can get back to working. A lot of us people are working out of home. We are trying to do meetings. Instead of seminars, we are doing webinars. But it is not possible for all people to work out of their homes. So we have to get out, we have to get the economic activities back, and for that we have to take care. So then we have to take care of recreational activities, the physical activities of people. People have to get out, people have to exercise, people have to take care. So we have to wear a mask. The person in front of us has to wear the mask. We have to hold hand hygiene very properly. We have to take care that we don't touch our eyes, we don't touch our nose, we don't touch our mouth, and we keep washing our hands again and again and again. So this is a behavioral change which is required. These are social changes which have to come to the community and to the people. And this is coming very fast. Very soon, a lot of people in our society are learning, and they're learning very fast. Otherwise, people are getting stress, anxiety, tension, and depression because of the uncertainty which this pandemic has brought to us. So we have to take care, and we have to take care in all the sectors. We have to take care for the recreation spaces, for the shopping centers, for the work environments, for the housings, for the educational institutions, and all the other sectors of the economy. So in medical architecture, what we are seeing is the newer technologies, and all these things have to come and help our hospitals to come and help the community. So in the next slides, in the slides which I'm going to show you, I'm going to tell you that how the health sector in India is divided for rural areas, tribal areas, urban slum areas, and the hierarchy of hospitals in the urban areas. So Sanjay sir, may I have my slides please?
Already sir.
Okay, so maybe we could run the slides now. So I'll show them something on the slides. Yeah. So what you're seeing on this slide is that how we bringing in the paradigm shift in the planning, design, construction, and facilities management of hospitals, which is what is medical architecture. So in this, we are saying that we are in a state of emergency today. So this you can read. So maybe I go to my next slide now. And in the next slide, I'm going to tell you the 6 feet office. So let's see this film now. I've talked about it. This is Kurt's
with the ambition to put people safer and sooner back at work. We believe that a safe and healthy workplace is at the center of what's next. We have developed a 6 feet office as part of our total workplace concept. Cushman & Wakefield can get companies operational as soon and cost efficient as possible. We would like to inspire organizations and people about a safe and healthy workplace, finding a better work-life balance, and becoming more engaged with the ambitions of your organization. We would also like to invite companies to join us develop the 6 feet office project further from a technology perspective, facilities, or just good ideas to make work better. Thank you for helping us move this forward. Together we're stronger.
Okay, so that was the 6 feet office. So now I've talked to you about the primary, secondary and tertiary healthcare systems in India and how at each district in India we have a district medical college teaching hospital whose manpower, the 4th year onward students could be brought in to all these temporary healthcare facilities which we are setting up as institutions to take care of the quarantine needs of the people. Because today in Delhi, we've had a requirement of all those people who are tested positive for COVID have to be under institutional care for at least 4 or 5 days. So the questions are, when does the 0 day start? When did we get tested? When did we get the reports? And when is the 0 date for quarantine start in an institution? Until when would it last? So these are very difficult times. We should take care of people at home, home care, hospital at home, ICU at home, and chemotherapy at home. All these things have been made possible because of the COVID situation. Otherwise, the society, the healthcare professionals, and the community were not able to digest these facts that we could have healthcare at home. So maybe we could have the next slides, please. So then we have these levels of care. God forbid if we get these problems of passport people coming to the ration card people, which means if we go to the rural areas, the semi-urban areas and the large hinterlands which we have, then there is very little chance of people, because even if the healthcare facilities are there, either the electricity is not there, the manpower is not there, the systems are not there. So the healthcare doesn't work. It works at the district level and above. So we have to ensure that our rural areas, our tribal areas and urban slums, we find some local solution to the local problems we have of lack of manpower, lack of resources, and lack of political will to take care of these people. So maybe we go to the next slide. So this was the healthcare hierarchy of India and the numbers we have and all that. But the idea is that the demand is much, much more than what we can supply to our people who need the healthcare. So healthcare and provision of healthcare is going to be the next big election issue, and governments are going to be formed or removed because of the level and kind of healthcare which we're going to give to our people. So when we come to our institution level, a hospital level, what medical architecture and hospital architectures go to 2. We would have ANUJ sir to talk about the environment within a building. Let me talk all about the infrastructure and the requirements and the health systems at the international level. We have the World Health Organization, which brings you what science can do for us, what is the research required, how do we prepare a vaccine, how would the vaccine be delivered to all the populations of the world, what we can do at a regional level. Suppose we have SAARC countries like India, Nepal, Bangladesh, Pakistan, Maldives, Sri Lanka, and all around us. So these countries have porous borders, and if we take care of the problems in one country or in all the countries together, only then we can solve these issues. So maybe we could have the next slides, please. So now, in terms of planning of healthcare spaces, like Sanjay sir had said that in China they did a 1,000-bed facility in 10 days. So they have newer construction technologies, they have prefabricated, pre-engineered buildings which come up and which are plugged on and which are just to the foundation, and modular units are added. So these are the various typologies of healthcare buildings. So we could have a street pattern, we could have an atrium come galleries, we could have an unbundled courtyard kind of architecture, we could have a podium and a slab tower over it. So we could have a rural street kind of a pattern. So these are the various configurations we have for hospitals, and they've been developing over time. But what is the need of the hour is to set up healthcare institutions which could come up very fast and which could be temporary, which could be movable, which could be like the field hospitals which Colonel Saab could talk about, which could be working in Delhi today, and 24 hours from now they could be in Chandigarh or they could be Leh. Wherever they want, they could be shifted very fast. So we want newer construction technologies, newer methodologies, but spaces which are healing architecture, which are very good for the people and which give them the right kind of ambience. So all this Sood Saab is going to talk about. So maybe have the next slide, please. So then these are war-like situations. So there was a triage theory which came up in the Second World War. So we are hoping that this pandemic would give us newer theories of hospital planning and design. So what happened at the time of triaging? In triaging, we had limited resources and far more number of people to be treated. And in this case, they would just take care of the people who needed immediate, urgent attention, and the color which was black and green was not to be taken care of, and you took care of as many red patients as possible and save as many lives as you could. So now there is oxygen required, a lot of people require oxygen, much fewer of them require ventilation support, and there is a big shortage of hospital beds, ICU beds, and ICU beds which have proper intubation facilities, infection control, and staff who can take care of you. So on the next slides, we're going to tell you how we are adding spaces which are empty rooms, and how do we enter a hospital before we come to a normal hospital. So this is medical architecture and what we have for medical architecture. So let us see what is tomorrow's healthcare. So this is a film. So this film, let's have the film.
That's why our partnership with Philips is so important.
Philips' strategic design team is helping its customers by designing with tomorrow in mind, addressing the many clinical, operational, technological, and experiential changes at work.
We work with healthcare systems and hospitals that are really looking to transform care for their patients and also for their own staff. Our work really encompasses a variety of scales, from single room solutions to departments or even whole hospitals and enterprise master planning.
All of these things help to think about how we're going to deliver care for the next 10 to 20 years. Fantastic partnership.
Our strategic design team is integrated with data analysts, clinical consultants, and research strategists.
We really felt like it was critical to have another set of expert eyes to help us to really design areas that are reflective of the need of our modern patient base.
Our approach is very multidisciplinary, insight-driven, and people-centered. We do this because we're then able to gain better empathy in terms of what their needs are and their highest level challenges, so then we can take that and actually do relevant solutions.
My experience in working with Philips is that they've been collaborative and they have heard the voice of our referring providers, our staff, our patients, and our families. I've learned some things throughout this process working with the design team around really making flexible and tunable environments so that you can plan for the future if in fact the needs of the department change.
The benefit of design and research working together when it comes to customers is that we have an eye on the future and we can see what's coming in research, but then we can take that and apply it to everyday challenges that they're facing right now. So everything that we're doing here is really directly informed by customer needs and by their input.
This broad consulting offering and approach has enabled many of our customers to see significant improvements related to the quadruple aim in healthcare: reducing wait times, improving volumes, increasing patient satisfaction, and improving the experience for patients within their organization.
The workflows that we developed helped us to assure that our patients and their families had the best experience as they were impacted by their care at the organization.
I would say our relationship with Philips has been a very gratifying one. They're working in a co-creation model that is really allowing us to be absolutely innovative and creative.
Lives of 3 billion people by the year 2030. And the strategic design consulting team is committed to doing its part by challenging assumptions, by putting people first, and by designing tomorrow's high-performing health systems today.
Innovation and you, Philips.
So now these are the Chinese modular hospitals which come up very, very fast. So these are pre-engineered buildings which could be plugged on to a central spine and they could be added. So the army and those standards which do scales of accommodation, and they keep adding hospitals which are pre-designed per se, and they could be just flexible, continuous, and they could change as per the needs whenever, wherever are required. So maybe we have the next slides, please. Or I could come back to all these after Anuj Sood has made his presentation. So maybe we could have him on board now. And I could continue with these after that.
Anuj Sood will be able to draw.
Hello, sir. Should I continue? So, okay, maybe have the next slide, please. May I have my next slide, please? Okay, sir. So in my next slide, I would come to patient-friendly hospitals, hospitals which are healing environments, which take care of all the stakeholders that we have in a hospital. When we started doing hospitals, we used to have hospitals designed for the professor. We could save steps for the professor. Then we would take care of all the stakeholders, and now we have patient-friendly hospital. So when we have a patient-friendly hospital, it's almost like taking care of the patient in the home environment. It's almost like the hospital coming at home to the people in their home environment, giving them the care in the economic condition there are. So these are the innovations and creativity that we require for conditions like India. So what people have done is, suppose we had a incubator and we could have a place where we could take care of a baby in a nursery. But then we came up with an idea of kangaroo care, wherein the mother keeps the baby very close to the chest. The mother is very happy that the baby is next to her. The baby is very happy because she can feel the mother, and both of them take care of each other and at a very low cost solution. So we have to find appropriate solutions for our culture, for our place, for our economy, and for our people. So for this round, I would like to speak this much only, and I would be very keen and very happy to answer any questions that come to me. Maybe I now hand over to my senior, Professor DINESH BHARDWAJ, who has been practicing Vastu wisdom in architecture, and he'll tell us about Ayush care, about Ayurveda, Siddha, Unani. We have the International Yoga Day coming tomorrow. How the Indian systems of medicines can take care of Indian people in the Indian context. Over to DINESH BHARDWAJ.
Thank you, Mr. DEWAN. Sanjay sir, can I have my first slide, please?
DEWAN sir, you will continue on this?
Should I continue?
Yes, sir.
Okay. So I have a few slides to show. Maybe let me show these and then we'll go to Bhardwaj sir. So I've talked about these modular spaces. Maybe we go to the next slide, please. So in the next slide, we're talking about indoor air quality and the positive and negative air pressures in the rooms of hospitals. So in infection control, everybody has said that it is an airborne infection, that the infection goes from one person to another through the airborne pathogens, bacteria, and viruses, and whatever you name, germs, and whatever you name them. So we have to ensure that there's a positive pressure outside. We have an anteroom. We come to a place which is little negative. So it was 2 positive outside. We have 1 positive in the room, and from the room we have a negative pressure into the toilet, and from the toilet we have an exhaust fan which is throwing the air out. And in the air conditioning system, we have to ensure that we are extracting more air out and we are supplying lesser air. So the principle is that we are drawing out more air and we are supplying a little less air. So in a hospital situation, we are having 100% fresh air, but where are we removing the air and how are we removing the pathogens from the air is very, very important. Because what we know today of hospitals is you go to a hospital with 1 problem and you come back with 2 or 3 more problems, which we call as hospital acquired infection. That is why we have to take very sincere care that COVID and non-COVID patients are to be segregated and separated. Ideally, we should have dedicated hospitals for COVID care, and at the same time, we have to take care of all the other problems that we have. So we have births which are happening, we have heart diseases which are happening, diabetes which is there, and all the kidney problems and all dialysis and other things, they have to happen. So we have to make sure that hospitals are very patient-friendly spaces where you go with your disease and you come back cured. Once upon a time, hospitals were places where the dying would go and the dead would come out. We have to make sure that hospitals are positive, happy places. The next slide, please. So now, indoor air quality, as I told you, is a very, very important thing. So we have to have filtration. We have to not only stop the pathogens at the HEPA filters and the filters we have, but we have to kill them also. So we have to ensure that we don't spread the infection from one place to another by proper passive, active and mechanical means and all that. So we have to take care of UV lights, and so UV light is very bad for skin. So UV light is to be applied at air handling units and other spaces upwards where there is no contact with human beings. So Florence Nightingale had said that a hospital should be a place which does not do any harm to the patients. So we have to ensure that we don't do any harm to our patients. Next, please. So these are the touchless hospitals, the newer technologies. So you measure the temperature of people, you sanitize the people, and all these things, toilet fixtures, the fittings, the other things, wherein we don't touch and we use the newer technologies that have come. Next, please. So this is the AI and this is the use of apps and the other technologies. This I've talked about in protective environment already. That is all I have to say. Thank you very, very much. Over to, okay, let's see a film. It's always good to see a film.
Lives through meaningful innovation, and we've got a great story to tell about our future. The world of healthcare is changing rapidly. More and more people are taking ownership of their health and well-being. At the same time, the industry is transforming and embracing technology in new and innovative ways. For Philips, with a presence in both personal health and professional healthcare, this presents an opportunity to extend our leadership in health technology by focusing relentlessly on our customers' needs. We like to visualize healthcare as a continuum, starting with healthy living and prevention, precision diagnosis and personalized treatment, through to care in the home, since it suggests the notion of continuous care. And we want to join up the dots, ensuring care is seamless. In the consumer space, this approach encourages people to take an active role in the management of their own health. All around the world, we make a difference to people's lives by delivering locally relevant, connected solutions that support healthier lifestyles and those living with chronic disease. In the clinical space, we're focusing on delivering integrated solutions, combining systems, smart devices, software and services that we co-create with our partners and customers to improve patient outcomes and productivity. Increasingly, we're partnering with customers in new business models, no longer selling products in a transactional manner, but engaging in long-term strategic partnerships to innovate care. Now it's time to implement our strategy with flawless execution. And how will we do this? By better serving our customers and improving quality. By boosting growth in our core businesses. By building winning solutions along the health continuum. It's a big challenge, but one we're ready for. thanks to the capabilities and experience we've built up over more than 125 years as a people-focused innovation company. With every step we take, we'll move closer to our vision of improving the lives of 3 billion people a year by 2030. What greater challenge could we wish for? There's always a way to make life better.